everyone. Welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I am your host, Kimani Hendricks, Multimedia Communications Coordinator for MS Focus, and today, Dr. Ben Thrower will be answering your MS-related questions for the next hour. Before I introduce him, I would like to address those who do have some questions. If you are watching from Facebook Live, you can type your questions into the comment section of the stream, but if you are on Zoom, you can either utilize the raise hand feature by clicking the icon at the bottom of your screen and utilizing the Q&A and chat box features. If you are on a mobile device and would like to raise your hand, press *9 and wait until we ask you to unmute. Dr. Thrower is the medical director of the Andrew C. Carlos MS Institute at Shepherd Center in Atlanta, Georgia. He previously served as the medical director of the Holy Family MS Center in Spokane, Washington. Currently, Dr. Thrower is the Senior Medical Advisor for MS Focus and enjoys contributing to our quarterly magazine. Dr. Thrower, I'll turn it over to you for opening comments.
Great. Thank you very much. And thank you to everyone who's joining in, no matter what format you're doing so. Thank you to all of the folks at MS Focus for all the work you do. And with that, let's throw it open for questions. And hopefully I have some answers to go along with them.
All right, so the first one I got from Gus. It's not a question, he just says DMTs and alcohol.
So in general, there's not any direct contraindication between being on any of our MS disease modifying therapies and drinking. We're gonna, with some of our disease modifying therapies, we're going to do periodic lab testing to look at your liver functions and different immune parameters. In general, with alcohol, just health-wise, we want to keep it in moderation. Do be aware that if you have any walking or balance issues, alcohol may hit you a little harder than someone else. You may find that your balance is even a little more impaired, even though you're not really intoxicated. So just common sense, but no direct contraindications.
And Angelique asks, is interferon, or can it cause cholesterol labs to increase?
So generally, interferons would not make your cholesterol labs go up. With the interferons, usually the blood testing that we're doing, it's just blood counts and liver function studies. We don't routinely check cholesterol levels with interferons. Your primary care doctor is going to want to do that. The reason we don't is because usually those interferons are not going to have any effect on your cholesterol.
Someone asks how to increase white blood cells.
So the question, I guess what I would have is, why are the white blood cells low? So, if you're on a medication that lowers the white blood cells, some of our medications, we might expect some certain categories of white blood cells to be low. For instance, your drugs, your S1P receptor modulators, that's going to be Gilenya, Zeposia, Mayzent, Ponvory. Those drugs are designed to lock up some of your lymphocytes in the lymph nodes. And so someone on one of those medicines, you would expect the lymphocytes to be low. If you're on a B cell therapy like an Ocrevus, Kesimpta, Briumvi, those types of drugs, we would expect certain B cell subsets to be low. So the question is, why would they be low? First off, we would want to be careful using any medications that stimulate white blood cells. For instance, drugs like Neupogen, which is used sometimes in cancer patients, will increase white blood cells, but it's kind of stimulating your immune system, which is the exact opposite of what we want to do in multiple sclerosis. So yeah, there's a lot of nuances to that question.
James wants to know the difference from Empira as a compound.
So Empira, the generic on that is dalfampridine, and before there was dalfampridine or Empira, there was the compounded 4-aminopyridine. They are all very similar molecules. Dalfampridine or Empira probably has a little bit longer half-life. It sticks around in your system longer, but ultimately they all do the same thing. They work on potassium channels on demyelinated nerve fibers, and they have the potential to improve electrical conduction. So they're not repairing damage, but they might make that area of old damage function a little bit better. So what we see in some people with these molecules is improved walking speed, improved leg strength. Although dalfampridine and Empira weren't specifically studied for this, we always thought of 4-aminopyridine, that the compounded version, as something that would improve anything that was related to nerve fiber fatigue. So if you had a symptom that worsened with exertion or heat exposure, we always thought of 4-aminopyridine as something that can improve that. One of the mysteries with all of these molecules is, why don't they work for everybody with MS? In reality, they seem to work for about 40% of people with MS, and we don't know why that is. If you try one of these drugs, I tell people, give it about a month. You're going to know within a month whether you're in the responder group or the non-responder group.
The person who asked about how to raise white blood cells, they said they use fingolimod. Don't know what that is.
Yeah, so fingolimod is the generic on Gilenya. So again, we would expect your lymphocyte counts to be on the low side when you're on fingolimod or Gilenya, because that's the way the drug works. It's locking up some of your lymphocytes in the lymph nodes so that they can't get out and cause inflammation. One of the questions is, well, how low are we okay with the lymphocytes being? And so there's no absolute right answer to that. Generally, I'm okay with the lymphocytes being as low as 200 to 300. And then we also want to look at how you're doing physically. If your lymphocytes are low, which again, they're supposed to be, but you're having a ton of infections, well, then maybe they're a little too low. Generally, if we reach a point that we're nervous about what your lymphocyte count is on fingolimod or any of the similar drugs, we might lower the dose. We might go to every other day dosing to let them come back up a little bit.
The same person wanted to know what the best drug was with less side effects. I'm assuming.
Yeah, so we have almost 30 FDA approved disease modifying therapies now. So the best drug is the one that's the best drug for you. Across humans, the best drug for you may be different than the best drug for someone else. So ideally, what we want with any of these drugs is we want no relapses, no progression of disability, no new MRI lesions, and you tolerate it. You're not having side effects. It fits your lifestyle. So if fingolimod was not a fit for you, there's certainly a lot of other options that are out there.
Eileen asks, how do I mitigate the adverse effects of delayed shivering with Copaxone injections? Is there something I can do before injections to mitigate the post-injection reaction?
Yeah, we wish there was. So when you look at glutamate acetate or Copaxone, the major side effect risk usually is either the injection site itself, redness, itching, a lump, or the post-injection reactions that she's describing. And we think those post-injection reactions may represent the person bumping into a capillary and getting a little bit in the bloodstream. There's nothing dangerous about it, but it can certainly be not fun to have the post-injection reaction. Sometimes trying different injection sites to see, maybe you have less capillaries in some injection sites than you do in others, and you're less likely to have that injection, post-injection reaction. But we've never really found a great medication. We've tried, things like antihistamines, and I've just never found anything that was consistently successful.
Jamie has a general question about COVID and wants to know what advice you're sharing with your patients. He says that they still mask when they go outside to the grocery store and they're not traveling.
So COVID, is kind of been a moving target. It has evolved over time. I would say we're in a much better place now than we were when we were dealing with Delta. The Delta variant of COVID was bad. I mean, people were, MS or not MS. I mean, people were getting very sick, ending up in the hospital, and some people dying. The Omicron variant that's out there now is still very contagious to people, but in general is causing less severe illness. There's no patent right answer, for how you protect yourself. There's certainly nothing wrong with continuing to mask. Certain people are, based upon their health and maybe the medications they're on, could be more at risk for COVID than others. If you're on a drug that might have some immunosuppressant effects, for some of our B cell therapies, for instance, you could have a little higher risk of picking up COVID. So I think, I wish I could give just an across the board answer that's right for everyone, but we all have different risk tolerances. No one's ever going to fault you for wearing a mask when you go out and about. I would say if you're going to wear a mask, get a KN95 or an N95. The KN95s to me are a nice compromise. They're a little bit more comfortable than the traditional N95s.
Agree. There's another COVID related question from Jody. She says that she's on Kesimpta and she'd like to receive the COVID vaccine. And should she have it 2 weeks after her dose? And she wants to know how it'll be affected if she is on DMT.
So Kesimpta, as one of our B cell therapies, does have the potential to make the COVID vaccine maybe less effective because you might not make as much of an antibody response. I do think with Kesimpta, because it's an every month dose, it makes sense to do it at the 2-week mark, or cut in between your Kesimpta doses. Realize when you get a vaccine like the COVID vaccine, your immune system does two things. It has a T cell response and a B cell response. So we can measure your antibody response to COVID vaccination. And I think it's not a bad idea to do it after you've had COVID vaccination, just to see what kind of response you got. We don't have a great way of measuring your T cell response. What research has suggested is that everyone on B cell therapies, including Kesimpta, still makes a good T cell response. So even if you don't get a great antibody response, you still should get some protection from the T cell response. If we were having this discussion a year ago, we would have talked about maybe giving the product Evusheld, which is COVID monoclonal antibodies. We offered that to people on B cell therapies who were not making a good antibody response. The thought was, if you're not making antibodies, we'll just give you the COVID antibodies. That drug has had its emergency use authorization withdrawn as of January of this year. So we really don't have a COVID monoclonal antibody to offer people at this point. We'll watch and see if somebody comes up with one. But as of right now, we really don't have anything other than the vaccine itself.
Mark does not specify what symptoms he's experiencing. So this is a general question, but he says, how do you know when your symptom is MS related or not?
Yeah, so it probably depends on the symptom. If you're having, something that would be a typical MS symptom, let's say you woke up and you've lost vision in an eye, something that would be very typical for optic neuritis. Well, statistically, that's probably going to be MS related. If it's a more generalized symptom like fatigue, that's tougher. A lot of medical conditions can contribute to fatigue. So it's really a process of elimination. There's a balance. We don't want to automatically assume that everything that comes up in your health is MS. On the other hand, we want to realize that MS could contribute. So usually it's a matter of reaching out to your MS team, kind of describing to them what symptoms you're dealing with. They may kick you back to your primary care provider because they have a suspicion that this is not MS. So it's a dance that goes on, and so sometimes it's a process of elimination.
An anonymous attendee asks, they say DMT transition from Ocrevus to Mavenclad. When would that make sense?
So again, think with any of the disease modifying therapies, think of what it is that you want. So how do we know you're getting an A on your MS exam? Again, it's that no relapses, no progression of disability, no new MRI lesions, and you're not having side effects from the drug. If you're getting all of those things, well, then we're pretty happy with whatever medicine you're on. If you're not getting one of those things, regardless of what therapy you're on, that's when we're going to start having that discussion about maybe moving to something else. Ocrevus is a very effective drug. Mavenclad is a very effective drug. So it's, if the reasoning for moving from Ocrevus to Mavenclad would be that either you're having side effects, lab abnormalities with the Ocrevus, or you're not meeting one of those clinical endpoints on relapses, progression, or MRI findings.
Not really a complete question, but Jamie asks TENS unit for nerves vibration plate.
So two different therapies. So TENS units, the idea would be that you're stimulating a nerve that's maybe not getting the signal due to demyelination. So if we can't get a signal to a muscle from brain to spinal cord to muscle, or if we just bypass that. So some examples of that would be things like the Bioness units or walk aid units or the new neural sleeve that are used to treat foot drops. So those would be kind of examples of a TENS type unit or a functional electrical stimulation. People who work with something called FES bike, functional electrical stimulation exercise bikes, that's a way of maybe improving leg strength and endurance by using these peripheral nerve stimulators. Vibration plates are something different. So that if people haven't seen one, it kind of looks like one of the old-fashioned scales to weigh yourself on. So it's a base that you would stand on, a podium that goes up, and then something that you would hold on to. That base vibrates at a really rapid rate. And so there is some data out there to suggest that using a vibration plate could help with balance in a person with MS. There's other data suggesting that it might help in people with osteoporosis, of a way of maybe increasing bone density. So yeah, two kind of different goals between TENS and vibration plates.
An anonymous attendee asks, are BTK inhibitors considered to be an immunosuppressant or an immunomodulator? And what does non-covalent and reversible BTK inhibitor mean for, forgive me, phenobrutinib?
Yeah. So there are there were four BTK inhibitors coming down the line. Biogen has kind of dropped theirs. So there are three in the works. They're all very close. They're all of their studies right now are on a temporary pause due to some liver function problems. So as the FDA and the research groups sort those out, hopefully those studies will resume. We're kind of excited about the BTK inhibitors. It's a new mechanism of action. They work on B cells, kind of like our current B cell therapies do, but they hit it from a very different angle. So the current B cell therapies, Ocrevus, Kesimpta, Briumvi, rituximab, these are monoclonal antibodies that target the CD20 receptor on the surface of the B cell and knock the B cell populations down. All of these BTK inhibitors actually cross the blood-brain barrier. They work inside of the B cells and they affect how the B cells function. So they do bring something different to the table. I would argue that they have the potential to be mildly immunosuppressant. The thing that we're kind of excited about, and we need to see kind of how this pans out in real life, is there is this concept in MS of smoldering or low-level inflammation. Is that driving some of the progression that we see in MS, where there's no new MRI lesion, there's no relapse, there's just someone's kind of getting slowly worse? We think some of that progression without relapse is loss of neural reserve. Could it be that there's this low-level inflammation that's driven by a cell called microglia? A lot of research focusing on that cell now. And there is a hope that maybe BTK inhibitors help address that type of kind of low-level inflammation. We'll see. We'll see how they, when they get FDA approval, but it will really be the first big new class of drugs that we've had in quite a while.
Edna wants to know what will help with fatigue.
So fatigue is a big topic in MS. I just realized there are two types of fatigue that are as a direct result of MS. There's the nerve fiber fatigue, which is more the exertional heat-related fatigue. And then there's fatigue that just comes on for no reason, that we call lassitude. Both of those have treatment options available. With lassitude, we want to kind of address, make sure the person's got adequate sleep, number one. If sleep is adequate and the person is still fatigued, then we look at making sure the person is in a good exercise program, because over time, energy levels can improve with regular exercise. And then we talk about medications that might help with lassitude, ranging from things like amantadine, modafinil, or Provigil, are modafinil, Nuvigil, the true stimulant drugs, your Ritalin, Adderall type medicines. And then sometimes there might be supplements that could help with energy levels. There has been research in the past looking at the supplement acetylcarnitine that might help with fatigue. The supplement lavender, which is just ground up lavender flowers, that ironically, we normally think of lavender as something that has a calming effect that you would take at bedtime. But in a study where they used it as a morning dose, it did help with energy levels in some people with MS.
Wendy says she was diagnosed in 95 and took Avanex from 97 to 2019 and wants to know how often it is recommended.
So Avanex was one of our original 3 medications when we were kind of talking about ABC drugs: Avanex, beta-seron, Copaxone. The interferons, they did work well for a lot of people. So it probably is not as common now that we would recommend one of those platform therapies, either interferons or glutamin or Copaxone. Not because they didn't work, but because we do have options that we think are probably more effective now. And a lot of people just are not excited about being on an injectable medicine. Now that we have oral medications or medicines that are given intravenously on a less frequent basis, I would just say it's not as common that we would use Avanex, but there still are people on it. We have people on beta-seron that have been on beta-seron since 1993, when it was the first FDA-approved treatment out there.
Vishera wants to know what the best DMTs are for minorities, namely African Americans. She says she's on rituximab and wants to know if that's best.
So again, I would say that you have to be careful saying something is best for everybody out there, because we're all individuals, and something that works beautifully in one person might not work as well in another person. That said, there is a lot of research now saying, are there racial differences in not only how MS acts, but in how the drugs act in that person? So we know that in African-American individuals, that MS has the potential to be a more aggressive disease. So I'm biased towards wanting to be as aggressive as possible in everybody with their MS, but especially in the Black community. I really try to convince our Black patients living with MS that let's not mess around with this. Let's be as aggressive as possible. And I think rituximab certainly fits in with that more aggressive therapy. I like rituximab. I think it's a great drug. So what rituximab, like the other B cell therapies, is designed to do is knock those the inflammatory B cells down, and then your body's going to make more. Most people tend to repopulate their B cells at about the 6-month mark. That's why most people, we do 6-month dosing. There is data out there suggesting in the African-American community that Black people may repopulate their B cells earlier than other people do. So it's something we need to keep a watch on. And if it looks like the rituximab at 6-month dosing is not quite cutting it, the person's making more B cells before that 6-month interval, maybe we back it up a little bit. Maybe we do a 5-month or a 4-month infusion with the rituximab.
Rosemary says, I'm 70 years old, just DX last year, never been on an EMT, and I'm having trouble walking. Am I too old to begin a DMT? Also JC+.
So no one is too old to start a disease-modifying therapy. And when we look at the bell-shaped curve of the age that people are diagnosed with MS, the middle of that curve is going to be in the 30s or so, but the curves go a long ways in both directions. And so we do see some people whose immune systems just didn't read the textbook, and so they're diagnosed at 65 or 70. It's unusual, but it does happen. I sometimes wonder in those individuals, were they maybe having milder symptoms that just didn't get picked up, much earlier in life. And so maybe they really didn't develop MS at age 70. They've had it for a while, but we just didn't pick it up. So really any of the therapies, are on the table in a 70-year-old, just like they are in a 30-year-old. When we look at research, research likes to look at the perfect population. They want 18 to 55, no other health problems. Well, humans are not perfect. And so we know that there are individuals, outside of those age ranges who are going to need to be on treatment. the other comment I would make when she says she's JC virus antibody positive, I would want to know what that number actually is. So realize when we do JC virus antibody testing, the test technically says you're positive at a level of 0.4. But if you look at the safety data of natalizumab or Tysabri, really people between 0.4 and 0.9 who are technically positive don't have much different safety than people who are negative. So there is a group of people who are JC virus antibody positive who could probably still use Tysabri safely.
I just want to let everybody know who is asking questions that we are going in order by us receiving them. So just bear with us. I see a few people typing the same question in the Q&A. So just hold on, bear with us. Thank you for your patience though. Judy wants to know if there is any recent research looking at DMT therapy and frequency or occurrence of additional autoimmune diseases.
So yeah, that's anytime disease modifying therapy gets FDA approval, there's the phase 3 study where you're looking at side effects and safety and efficacy during that study phase. But then there's ongoing safety monitoring, with any of these drugs that's going to occur. So healthcare providers, people in the MS community are reporting side effects that they see as an ongoing issue. There has been some research looking at the incidence of maybe inflammatory bowel diseases that might pop up in people on B-cell therapies. The risk seems to be very low, but there have been some case reports there. So that would be a second autoimmune condition. Probably one of the biggest ones would be with Lemtrada or alemtuzumab, where very, very effective drug, but you do see a risk of B-cell driven autoimmune diseases and thyroid diseases that can pop up in people on that. So those are the two that I can think of right offhand.
Edna wants to know what the best drug is for primary progressive MS.
So, as far as disease modifying therapies go, really there is only one FDA approved treatment for primary progressive MS. That would be Ocrevus. Do we sometimes try things off label? We certainly can, but in terms of something that's FDA approved, that would be the one that we're looking at. There is a study out there called Caliper that is looking at an oral therapy. That study is being done in primary progressive MS with the BTK inhibitors, and I cannot remember which one right offhand, but one of the 3 BTK inhibitors is still in testing. They have a primary progressive study as well.
Bridget says, I've heard that with regular use of cannabis, even edibles, it can eventually cause cognitive issues in people with MS. Is this true? And are there any workarounds for someone who benefits from cannabis use?
So individuals, responses to cannabis vary quite a bit. And so we see individuals who have really high tolerance and they don't seem to have much in the way of cognitive side effects. And there are people who are just more sensitive. There is a risk. So there was a study, I believe a year ago, that looked at a group of people with MS who were using various cannabinoids to treat different symptoms. And they did cognitive testing at baseline in these individuals. They then had one half of the group stay on their cannabinoids. They had the other group go off and they repeated the testing. The group that went off did see improvements in their cognitive functioning. So it's not something that would say that you can't use cannabinoids. It's a risk-benefit ratio. I suspect if we did a similar study with baclofen and tizanidine and gabapentin and Lyrica and a lot of the drugs that we use for symptomatic management, we might see similar results. A lot of our medications might have a little bit of a cognitive side effect. So again, you just have to look at the individual risk and benefits and try as much as you can to get away with as low of a dose of whatever cannabis product that you're using. Find a dose that gives you that symptom control, whether it's managing spasticity and spasms or central neuropathic pain or bowel or bladder symptoms without giving you the cognitive side effects.
Dr. Thrower, Anthony thanks you for addressing acceptable low lymphocyte counts while on Gilenya and wants to know your view what, in your view, is an acceptably low white cell count number while on Gilenya?
So again, I'm okay with lymphocyte counts, in the 200 to 300 range, as long as the person's not having an increase in infections. I don't think there's any absolute consensus. I see, MS physicians and healthcare providers who get a little bit nervous at 500. So again, it's going to probably be on an individual healthcare provider basis as to what they're comfortable with.
Leah says that she's had an MRI that said she had several small flare hyperintensities. She says, I've been told that I don't have relapsing remitting MS. And he said there's a chance that I could have primary progressive MS without lesions. Can something like this happen?
So with that FLAIR, so that's is FLAIR, so fluid attenuated inversion recovery. That's just kind of just a derivation on how we look for the bright spots on MRI. It just makes them a little more obvious and easier to pick up. Primary progressive MS is tricky. Some people with primary progressive MS don't have any brain lesions. It's all in the spinal cord. I've seen individuals with primary progressive MS that it really was difficult to see their spinal cord lesions. And as MRI technology has improved over the years, I have individuals that we didn't see their spinal cord lesions on older MRIs. And as we got into 3T MRI and better techniques, now we see their lesions. Sometimes they're kind of subtle. So yeah, primary progressive MS can be tricky. It may or may not have brain lesions. The spinal cord lesions can be hard to see. And only about 50% of people with primary progressive MS actually have oligoclonal bands, one of the markers of kind of immune overactivity in the spinal fluid on lumbar puncture.
Lori asks, what type of treatment is available for those over 65?
I think any of our treatments, we don't magically flip a switch and say you're 65 and therefore these drugs are off the table for you. So anything is still on the table for people over 60, 65, 70. There is this trend that as we get older that our immune systems do calm down. So there's a question out there, do people with MS need to be on disease modifying therapies for the rest of their life? And maybe not. So there was the study last year, Disco MS, that looked at that question that suggested that maybe some people who've been very stable on typically our older therapies, our interferons and glutamate was most of what was in that study, that maybe they could safely go off at some point in their life. We would love to have a blood marker, a biomarker that tells us when people can go off. But as to specifics of her question, I wouldn't say her age takes any therapies off of the table for her.
Aaron from Facebook wants to know which helps with fatigue, B6 or B12.
So if your B12 levels are low, obviously getting them corrected would certainly help with your energy levels. There is some suggestion that B12 deficiency is a little bit more common than the MS population, so we check those pretty regularly. If your levels are generally running okay with B12, maybe just taking an oral B complex is going to kind of cover all the bases for you. So maybe rather than trying to be specific about B6 or B12, assuming your B12 levels are normal, just get a good B complex so you're kind of covering the bases.
An anonymous attendee says, when you say no progression of this ability to see if a medication is working for you with primary progressive MS, would that still be the criteria? It seems like progression may still happen even without any disease activity.
Yeah, and so with primary progressive MS, the stopping of disability is the probably treatment marker, because people with primary progressive MS really shouldn't be having relapses. They typically don't have a lot of new MRI activity, so that's a great point. That population of folks, it really is stopping the disability. But what if, and this person raises a great question, what if we don't stop it? What if we just slow it? How do we know that we're slowing that disability down? And are we really doing something by having the person on treatment? That's a really hard question. And so it's easy to see if you're looking at 1,000 people in a study, this group of people was not on treatment, this group of people were, and you can see the difference. In an individual on a daily basis, sometimes it's a little bit trickier. And I think we do struggle with that, to be honest. And, are we truly making a difference? It's easy to see if you're stopping disability, but what if you just think you're slowing it? Sometimes the only thing you could do is say, well, we can always go off of treatment and see how you do without it. I'm not a big fan of doing that if the person's tolerating their treatment, because the consequences could, the price you pay for that could be high.
Jennifer asks if you have any advice for legs and arms that have a lot of tingling spasticity. She says that she stretches and takes baclofen and carbamazepine.
Yeah, so she's hitting on two different symptoms. So the spasticity or tightness would be one, and so I mean she hit really two of our major treatment avenues. So stretching, and more stretching is your first line of defense against tightness in the muscles. We can't stretch too much, and so we really want to make sure people have a good stretching program. Then we get into the medications like baclofen. Typically with baclofen, we're going to go up on the dose until one of several things happens. Either the person's happy with the degree of symptom control, or they start getting sleepy, or they start getting too wobbly. So sometimes with baclofen, we get rid of the tightness, but then we unmask underlying weakness, and the person looks then ragdollish, and that's not what we're trying to do. Tizanidine would be the other treatment. It hits spasticity from a different angle than the baclofen. We sometimes do use them together because they have different mechanisms of action. And then the cannabinoids, cannabis, would be another thing we would put on the table for potentially managing muscle tightness. The tingling end of things, so that's what's a sensory symptom. So really where carbamazepine would work is if that tingling has become uncomfortable. So if you just have an odd extra feeling, tingling, water's running in my legs, there's a bug crawling when it's not there, we call that a paresthesia, or an extra feeling. If the extra feeling becomes painful, then we call it dysesthesia. Carbamazepine really works for the dysesthesias. It might not get rid of all of the tingling. It's not going to make sensation normal, but it may tone down any discomfort that you have if from those extra feelings.
James wants to know your recommendations as to how often one can get the COVID vaccine.
So if you go, I would really recommend to people look at the National MS Society website. They've got a great page that with current COVID recommendations for people with MS. Some of that varies a little bit depending upon age. Some of it varies depending upon whether you're on a disease-modifying therapy that might have some immunosuppressant effects. So I would refer the person there because it's really well done.
McKinley asks if you could describe the cause of the MS hug, and would you recommend exercising through it?
Yeah. So the MS hug is that kind of belt-like tight sensation. It can be in your abdomen, it can be up in your chest. We think in most people it's a form of spasticity or muscle tightness. I think in some people it could actually be a form of a dysesthesia or an extra feeling, but typically I would put it in the spasticity family. So we can manage it by, with the same antispasmodics, your baclofen, your tizanidine. Whereas we talked about stretching for spasticity, this is one where stretching is a little tough. How do you stretch these muscles? If it was in the chest, you could argue that I might be able to stretch those by using something called an incentive spirometer. These are the little clear plastic tubes with a colorful ball in it, and you breathe in and you're trying to really expand your rib cage. Maybe that helps stretch those muscles a little bit. So if you have that symptom during exercise, if you keep pushing, I don't think you're harming yourself in any way, but it's not like you're going to get over a hump and the symptom's going to go away during exercise. It's probably going to stay there during that bout of exercise. If you can tolerate it and it's not limiting you in any way, there's nothing wrong with continuing to exercise. If it is, if it's really bothersome or painful, you might stop, with that given day, let it resolve. Maybe talk to your healthcare provider team if it's limiting your exercise and say, hey, what can we do to maybe keep a lid on this symptom so that I can continue with exercise?
Molly from Facebook says that after going through her old Army medical records, she was actually diagnosed with IBS in 1992 and has read that you have a greater chance of developing MS if you've had that, and just wanted to know what your thoughts were.
So if you have one autoimmune condition, then you might be at a little higher risk for other autoimmune conditions. That being said, irritable bowel syndrome is pretty common in the general population. Most people with irritable bowel syndrome are not going to go on to develop MS, but the risk might be a little bit higher if you've had that one autoimmune condition. It does get into issues, when you've been in the military and you have an MS diagnosis, you get into issues about, is your MS service connected or not? And there's specific rules that the military has, and I can't remember if it's 5 or 7 years within separation. If you develop MS symptoms within that time period of separating from the military, they consider your MS to be service connected. If you had symptoms that were clearly related to MS while you were in the military or within that period of separation, even if your MS wasn't diagnosed, but if we look backwards and we say, wow, this person had optic neuritis, they didn't diagnose their MS, but it clearly was their first MS attack, you can make an argument for service connectedness. I don't think they would allow irritable bowel syndrome to be that clear cut of an MS related symptom that you would be service connected just based upon the irritable bowel syndrome.
So we've got 2 questions from SEMA. They want to know what your advice is about having high IgE levels in the 1800s despite being on Ocrevus. That's one. And then their next question is, what to do as far as having a persistent cough that's not going away for 4 months. They say they have difficulty breathing and want to know your suggestions. They started exercising with a respirometer.
So I would go with the pulmonary, the cough issues first. And so, there are a lot of different things that could cause a persistent cough. If you have swallowing issues from MS and you're having a little bit of very low level aspiration, that could give you a chronic cough. If you have, there's something called cough variant asthma, where you don't actually get wheezing, but you get this cough, the fact that they have some shortness of breath. So when you think about who do we go to first to help sort out the chronic cough and the shortness of breath, I would go with a pulmonologist first. Get pulmonary function studies, make sure there's not a non-MS related cause. If they give you a clean bill of health there, then maybe working with a speech language pathologist to do a swallowing evaluation to make sure there's not low level aspiration causing that cough. On the IgE, so that would not be a side effect of the Ocrevus. So what we watch over time with the B cell therapies like Ocrevus is there is a suggestion in some people that their IgG levels and IgM levels can sometimes slowly go down. There have been some suggestions that if your low IgG and IgM levels are low enough, maybe you have a little higher risk of upper respiratory infections. IgE is not something we typically follow in people on B cell therapies. If they're doing a panel, that may be why they're seeing it show up. High IgE levels, you worry about with things like allergic reactions and whatnot. So that I would probably start with that pulmonologist. Is this all tied in together? Does the person have some variants of reactive airways disease, like a cough variant asthma, and that's accounting for the chronic cough, the shortness of breath, and maybe the high IgE levels?
SEMA is confirming that she has a clean pulmonary report, and she says yes to the swallowing issue.
I would definitely get in with a speech language pathologist. The speech language pathologists or speech therapists in the MS world wear a lot of different hats. So they do the swallowing evaluations. Typically, they're going to get a modified barium swallow just to see how things are going for you. They do cognitive rehabilitation, and they obviously work with speech problems. So that's going to be probably your next stop.
Got a question, someone whose name I can't pronounce. They want to know, how does zinc and selenium help with immune system and white blood cells?
So people got very interested in things like zinc and selenium and vitamin D and elderberry, all of these things when COVID really popped up, because none of us wanted to get COVID. I don't think that zinc and selenium have a direct impact on MS function for most people. They may work as kind of to lower your risk of upper respiratory infections, but I don't think I've seen an effect, positive or negative, in multiple sclerosis. Megan Weigel, a nurse practitioner from Florida, does a lot of talks on alternative and complementary therapies, and she made an interesting point that as more humans started taking zinc to try to prevent COVID, they have seen a higher incidence of copper deficiency over people. So if you're taking zinc on an everyday, regular basis, it might be worth getting copper levels checked with blood testing. If you're just taking it periodically, I get a upper respiratory infection, I'm going to take, some emergency or something with zinc, and probably not an issue then. But so bottom line is, I don't think zinc and selenium are an inherently positive or negative thing as it relates to MS.
Edna wants to know if demyelination can be repaired.
Yes, so humans do have the capacity to remyelinate to a certain degree. One of the mysteries of human biology is, why don't we repair damage better? Other species do a really good job of it. For instance, you take a frog and cut their optic nerve in half, you can stick the two ends back together and it'll regenerate. And as far as we can tell, they have perfectly normal nerve function. Humans can't do that. So humans can repair myelin naturally to a certain degree. Even if we don't repair demyelination, you can still conduct an electrical potential across a demyelinated nerve fiber. It just isn't as effective and efficient as it was when the myelin was there. That's the underlying basis, we think, for nerve fiber fatigue or worsening of symptoms with heat or exertion. Obviously, the holy grail of multiple sclerosis care ultimately is neural repair. How do we, make everyone repair myelin better? And so there are a lot of different, pathways that are being researched to look at that. Things like mesenchymal stem cells, small molecules that we think might play a role in remyelination. So that is a lot of researchers are hot on that trail.
Jamie wants to know, what about alpha lipoic for spasticity or numbness?
So alpha lipoic acid has been studied in several small trials, and there have been suggestions of improvement in functioning. They mainly are looking at improving walking. I don't know that I've seen anything specifically looking at spasticity in the alpha lipoic acid trials. I would be skeptical that spasticity would improve, but in terms of improving walking overall by improving strength or sensation, I would say it's a maybe. There appears to be a glimmer of hope there, and certainly larger studies are being looked at for alpha lipoic acid. Most of these trials have done about 1,200 milligrams of alpha lipoic acid in multiple sclerosis.
Eileen says, my MD tried to switch me from Copaxone to a POMD, i.e. Aubagio and dimethyl and says that they've developed significant fatigue, gastrointestinal issues, HTN, and HA with these medications. Is there any other PO medication that I should try?
Yeah, so when you look at the different classes of oral medications, so Aubagio or teriflunomide would be one class. Your fumarates, you've got Tecfidera, the generic dimethyl fumarate, you've got the bifiratam, you've got these Vumerity would all be in that kind of fumarate class. Generally, if you've had side effects with something in the fumarate class, you could certainly try something else. So Vumerity, for instance, and bifiratam may have a lower risk of GI side effects than Tecfidera or generic dimethyl fumarate. So that, I would say that's a maybe. And then when you think about other oral medications, we've got the BTK inhibitors way out there on the horizon. You do have Mavenclad, which is an oral medication, and then you've got all of the S1P receptor modulators as a different class of oral medicine. So this is going to be Gilenya, Zeposia, Mayzent, and Ponvory. So those are all going to be options for her.
Anthony wants to know the advantages and disadvantages of switching from Gilenya to Zeposia, and says, are they functionally the same, since both are in the same drug class and operate on the immune system the same way, which is more effective based on available data to date?
Yeah, I don't, in terms of that last part, the effectiveness, I don't think that we can clearly say that one is more effective than the other. They are in the same class. They're all S1P receptor modulators. If you're up and running with Gilenya and you're tolerating it well, you've gone through your first dose observation, I don't see a big advantage in switching the established Gilenya patient, over to a different S1P. If you're starting from scratch, that's probably where the big differences come in. I would argue that Zeposia is probably a little easier drug to start for most people. There are probably fewer side effects when you're initiating the drug. So yeah, different patients. If he's established on the Gilenya and having no big side effects, I'm not sure there's a huge advantage in switching at this point.
An anonymous attendee wants to know the best treatments for MS symptoms, namely pain and burning sensations. They said they're on several, or they have taken several, and none have worked, and they're currently on Lyrica.
Yeah, so with the dysesthesias, or that burning hypersensitivity, I think generally you could put all of our treatments into one of two camps. You're either using anticonvulsants, so drugs that maybe were designed for seizures, as kind of a treatment. So these are going to be your gabapentins and your Lyricas, Tegretol, carbamazepine, Trileptal, oxcarbazepine are all in that camp. And then you have antidepressants that might work for pain management. Duloxetine would be an example of that. Your old tricyclic antidepressants like amitriptyline or nortriptyline would be in that camp. If you're not having any luck there, this is where medical cannabis comes in. There is good data out there for using cannabinoids for the dysesthesias like that. If those are not effective, then we usually get people in with one of our pain clinics. They sometimes have things that they're using way outside the box, kind of things way off label, like ketamine, lithium. Sometimes we look at surgical interventions like spinal stimulators to manage this pain. So there are still some other options that are probably available.
Dr. Thrower, I have an inquiry from SEMA and wants to know how they can get a consult with you.
So for us, if they will just reach out to, probably the easiest way to go is through Whitney Blake. It's WHITNEY .Blake, BLAKE, at shepherd.org, SHEPHERD. What she will do, so she's one of our case managers. She'll start gathering information, get records and MRIs and whatnot, and get you set up.
Awesome. I'm typing that into the chat for us.
Yeah, sure thing.
Okay, so Edna says that in addition to having MS, she also has rheumatoid arthritis, and that she's currently on Ocrevus, but it doesn't help with her arthritis, and wants to know what can help with that.
So, it's interesting. So Ocrevus is the cousin of rituximab. So both of those drugs do the same thing in the immune system. And rheumatologists do use a lot of rituximab to treat rheumatoid arthritis. So we're always hopeful that, maybe the Ocrevus and rituximab will cover both bases for us. The other drug that could, in theory, cover both bases would be something like Aubagio or teriflunomide. So when we take teriflunomide as a pill, it is metabolized into leflunomide. Leflunomide is an old drug for rheumatoid arthritis. I would say in general, Ocrevus is going to be a much more effective drug for MS than Aubagio would be. So that's the downside to going to Aubagio, is you're taking a step down. Sometimes rheumatologists will add therapies to the Ocrevus. I've seen rheumatologists add older drugs like methotrexate to a B cell therapy to try to get better control of the rheumatoid arthritis. So I would have her rheumatologist kind of maybe coordinate with her neurologist to say, okay, what else we got out there that might cover both bases for us, or is it really going to take a combination of medications to do it?
Another anonymous attendee asks, is there any information about long-term effects on for B cell depletion?
So over time, as we're on B cell therapies, it's almost like the immune system gets kind of sensitized to these. And so what we like to watch over time is we want those B cell therapies to knock down your B cells, and we measure that by CD19. So your CD19 counts on your blood testing should be 0. We would like for your total lymphocyte count to be normal, and we would like for your T cell subsets, your CD4 and CD8 counts to be normal, and your IgG levels to be normal. What I've seen in some people over time is those T cell subsets or the total lymphocyte counts or the IgG may start drifting downwards. And what we've done in some people is then just lowered their dose of their B cell therapy. There's a balance. We want the B cells to be low, but we don't want to, whack your immune system into submission. So that's, to me, that is the major long-term issue that we need to keep an eye on in people on B cell therapies.
Julie from Facebook asks, where is the best place to learn about treatment meds? I was just diagnosed 2 months ago and am in the beginning and learning of these med names and efficacies with people, etc.
Yeah, so there's just a wealth of information, and that's both a blessing and a curse. Newly diagnosed individuals sometimes I think feel like it's just a fire hose that they're trying to drink out of as they get just blasted with information. So the msfocus.org website, so the folks that we're working with today, is a great place to get information. The National MS Society, the MS Association of America, all great places. We have a lot of videos that we've done over the years that kind of look at different disease modifying therapies. So just take it in, at your own pace. Don't get overwhelmed by this. Use your healthcare provider team that's there. There's great information online, but at the same time, you want to be cautious sometimes with support groups. They can be wonderful, but realize when someone with MS tells you, I did great with this drug, or I did horribly with that drug, I had a lot of side effects, that is their unique individual experience. You can't extrapolate that necessarily to everybody with MS. So your MS is your MS. And so, listen to other people with MS who've been dealing with it for a long time, but do realize that their experience may not be your experience.
So I've got 2 questions from that wonderful attendee whose name I can't pronounce and wanted to try. Have too much respect for names to get it wrong. So they want to know if MS can be cured 100% and what's the best drug for relapsing remitting MS.
Yeah, and I feel like sometimes I'm a broken record when we talk about the cure thing. Realize that cure means different things to different people. So for that person who just asked the question, who's newly diagnosed, a cure for that person might mean, I want to stop my MS dead in its tracks. I don't have disability now, and I don't ever want to have any disability. So if I had something that just stopped it right now, that would be a cure for that person. For someone who's been living with MS for a while and maybe has some mobility issues, maybe they're using a walker or a wheelchair, we want to reverse their disability. So in that person, we want to stop it and reverse what's been done. So that, again, cure means different things to different people depending upon where they're at on their MS journey. You can't say that there is a best therapy for relapsing remitting MS. And we can make some generalizations. We talk about highly effective therapies. So in general, if you looked at the top of the food chain, so what is the drugs that tend to have greater efficacy? Well, it's going to be your natalizumab, Tysabri, or the new biosimilar to Tysabri. It's going to be your B cell therapies. It's going to be Mavenclad. It's going to be your S1P therapies. Limtrada is going to be up there in the highly effective, range. Kind of, notch down from that, it's going to be, maybe your fumarates, or right underneath that, your Aubagio, and then kind of I would put Aubagio in with your old platform therapies, your interferons and glutamers in terms of effectiveness. Most MS centers, I think, are biased with relapsing remitting MS. We probably tend towards wanting to use the more effective therapies, as initial therapies, or certainly early on if someone's not doing well with a less effective therapy.
Dr. Thrower, I know that we're supposed to wrap up at 5:30. We're 2 minutes from that, and we have 10 questions left.
I think I'm good through 5:40.
Okay, awesome. Yeah. So I'll go to Edna. She says, I take tizanidine to help with spasticity. I can take up to 12 milligrams 3 times a day, but it doesn't help. What do you recommend?
So 12 milligrams 3 times a day, 36 milligrams a day is the maximum dose. So if that's not cutting it, then if you haven't done baclofen, you could certainly look at adding that to it. There's an old medication out there called Dantrium or Dantrolene. We don't use a ton of it in MS, but it sometimes has effectiveness. Your medical cannabis is going to be play a role. And if you've not seen a physical medicine rehab specialist, or sometimes neurologists do this as well, depending upon what type of spasticity you're dealing with, Botox might be an option for you. And then we get into things like intrathecal baclofen. So if you're putting in a baclofen pump and delivering, concentrated liquid baclofen right into the spinal fluid where it can have the best chance of working, would all be options.
Gus has a general question, I think. In your long career, what has been the one thing that surprised you most about MS? Wow,
that's a big one. I would say the varied nature of the immune response, how MS is really not a one size fits all. We think that in some people it's a little more T cell driven, some people a little more B cell driven. I think that's been humbling and surprising over time, that it really is quite a varied health condition across different people.
I was trying to save that question for last because it was the more general one.
That's a big one.
But
yeah.
An anonymous attendee says, what are your thoughts as to why my mobility function is consistently and significantly better between 11 p.m. and 5 a.m. He says this seems to baffle everyone. I'm 56 and was diagnosed in 1991, currently on Tysabri.
I mean, when you think about the human body, there's a lot of stuff going on, what we call diurnal fluctuations, just we have a circadian rhythm that can be on a monthly basis, or it can be within a day. And as you kind of go through the day, there are a lot of things changing in your body. Cortisol levels are changing, your core body temperature changes. And so something within that mix, when you think about those nerve fibers in the brain and spinal cord that have been damaged, and they're right on the cusp of working and not working, something as minor as a change in cortisol levels or your core body temperature could make a difference between, I'm walking pretty well, or no, I'm not walking very well at all. And so those are things, unfortunately, that you just don't have a lot of control over.
Jessica wants to know, is it possible that she was born with MS? She says that she lost her vision for 2 weeks when she was 9, and wants to know which tests should be done to solidify what she knows about her body, and that she's in the beginning stages of having a provider confirm that she has MS.
So people are not born with MS. You're born with the genetics to potentially put you at risk for MS, but then something has to turn those genes on. And so that's the environmental piece. We think that environmental piece, is going to occur sometime, early in life, probably by the age of 15 or so, you've had that environmental exposure. And there's a lot of the environmental research comes back to things like viral exposures, common viruses, Epstein-Barr virus that we think plays a role in fooling the immune system. So you've got the genetics and you've got the environment. So you are born with half of the risk, the genetic part, but then you have to have the exposure at some point in your life also.
Yeah, she says that she also experiences burning. Like she capitalizes that. And she says that she feels it when she eats the wrong foods and ingredients. Certain ingredients are in her body. And what do you recommend for relief?
So people, again, it gets back to that variability. And we do hear some people with MS say that there are things they do, like eating certain food, that seem to irritate their symptoms. And that's going to vary from person to person. So that's where the individual is going to have to do their own detective work and say, okay, if I eat X, I know I'm going to my dysesthesias. We don't think that those foods are necessarily causing new inflammation, but they may be kind of pointing out the old areas of demyelination. So again, I just think keeping food diaries, being mindful of that. Some people will do things like elimination diets where they'll kind of clean up their diet totally, see how they feel, and then start putting things back one at a time. So, okay, does this thing provoke my symptoms? Does this thing provoke my symptoms? So they kind of narrow it down.
Yeah, I really don't think there is a magic diet for anybody, really. I think that it is individualized. And McKinley had a similar question about diet and the best one for relapsing remitting MS, but yes, it's
Yeah,
trial.
so there were a couple of studies earlier this year that did look at some of the more common diets in MS. So the paleo diet, which is, when you think about the Walls protocol, that kind of includes a modified paleo diet. They looked at intermittent fasting, they looked at really low fat diets, and they looked at Mediterranean diet. There was some data for all of those in terms of maybe improving energy levels. I know there was a study with intermittent fasting that looked at markers of inflammation, some inflammatory cytokines, and showed that you could actually drop those. I don't like to see people doing radical, crazy diets where they take, a bunch of things out of their food. You want to pick a diet that is good for your health overall and that you can sustain for forever. You're not having to buy special foods. For me, I think the Mediterranean diet probably is the most reasonable in terms of just, you're not having to buy anything special. You can still eat good stuff. It's healthy for your whole family. You don't have to cook one meal for yourself and something else for the rest of the family. So yeah, if I was going to pick one, I probably would, not that it's more effective, but I think it's just more reasonable. I'd probably look at something like a Mediterranean.
Cosign, that's what I'm on.
Yep.
Tiffany asks, how long after I take Mavenclad am I considered immunocompromised?
So, we're going to see cell counts drop with Mavenclad, probably starting at about 1 month after that, that first course that you do. And then it's going to persist for, they slowly start coming back up, the 6 month, 8 month mark. And then you're going to do that second course a year later. So really probably starting at about a month, you're going to see some of those cell counts dropping. The important thing is, if you're picking up any extra infections, just let your healthcare team know. So Mavenclad, Serono has done a great job with collecting safety data with that drug, and the risk of infections, in spite of it knocking the cells down, the infection risk has actually been surprisingly low with that medication.
Bridget says that she's on Kesimpta and wants to know if glutamine is safe to take with that. She says that she was told to avoid things that boost the immune system.
So that's a great question. And a lot of the things in the supplement world that we tout as immune boosters, we really need a lot more information. So when you say it boosts the immune system, well, what part of the immune system is it boosting? Is it boosting the regulatory part or the inflammatory part? If it was boosting the regulatory part, that might be a good thing in MS. If it's boosting the inflammatory part, maybe not so much. That said, I wouldn't be that nervous about someone taking glutamine while they're on Kesimpta. I don't think that there's likely to be any downside in terms of it really overly stimulating the immune system.
Miss Coleman wants to know what can she expect going to an MS specific neurologist. She says that her neurologist referred her to one and she's seeing them next week.
So most MS neurologists are going to be part of a comprehensive team. So there may be things that are offered and done to you and offered to you. So there might be more outcomes done, things like timed 25-foot walk and 9-hole peg test and some cognitive testing. There are a lot of times as part of comprehensive MS centers, you're going to have more wellness and exercise options. They may have physical and occupational speech language therapists as part of their team. There might be research studies that are going on as part of that comprehensive team that you might be offered and to see if that's a good option for you. So it's usually that big comprehensive team. I think that's it may not be just that an MS specialist specializes in MS. That's really all I do. I don't think that's the big part of a comprehensive MS center. I think it's the comprehensive team that is what makes things special.
Lisa wants to know your input on the use of light therapy with MS.
I'm not opposed to it. I'm not convinced that I've seen anything great with it. I wouldn't want to see someone spending a ton of money on it if it's creating a financial hardship. I think it's something that I'm open to, but I'm not sure I've seen anything good with it.
Anthony wants to know, how would you size the risk of having the MRI contrast dye agents injected into us? There have been lawsuits about this due to allegedly lingering impacts of the dye on the brain and joints.
Yeah, there is some data out there to suggest that some of our older gadolinium dyes do stick around longer than we knew that they did. I'm not sure we've really gotten a complete grip on what the health risks are with that. I would say that in established MS patients now, we're doing most of our MRIs without contrast, just because as MRI technology has evolved, I think we're seeing what we need to see without the contrast. Maybe early on in the diagnosis, we get a handful of MRIs with contrast just to establish a baseline. Contrast does help us visualize active inflammation a little bit easier than without the contrast. Realize too, there are newer contrast agents that are being developed all the time that may have better safety than the older agents, but there is certainly a move to not do contrast in established patients.
This will be the last question for tonight, Dr. Thrower. Felicia from Facebook wants to know, what is the total significance of lymphocytes and MS?
So lymphocytes are an important part of our immune system. They help regulate and protect us from infections and monitor for precancerous cells. And lymphocytes really come in two versions. They're the B cells and the T cells. So MS is driven by the immune system, both B cells and T cells. So we can treat MS by sort of modulating that B cell and T cell function, but we want to do it judiciously. We don't want to just squash the immune system into submission. So depending upon what therapy you're on, whether it's a B cell therapy like an Ocrevus or an S1P drug, you may have different effects on the lymphocytes, and we always want to kind of keep in mind the mechanism of action of the drug, what is it supposed to do, and we want to make sure it's not doing too much to your immune system.
Dr. Thrower, I goofed. We literally have one question left. Can you
Let's go for it. Absolutely.
Okay. All right. So Caitlin says that she doesn't have access to an MS specialist, but is considering abnormal brain MRI symptoms. They said that, is there a resource for people in need of telemedicine consults or even just a brain MRI consult?
Yeah, I don't know of anyone that's doing telehealth for a new diagnosis. We certainly use telehealth for people with an established diagnosis, but typically with that, that first visit, we usually want those to be in person. It may be worth her traveling to a comprehensive MS center just one time, even just to get established, is this MS or is it not, and what's the game plan, and then hand that back over to her local community neurologist.
Awesome. Well, we got everybody. I'm so glad.
Very good.
Yes. So that is all the time we have for now. If you did miss any part of this conference, you can go to the Multiple Sclerosis Foundation's Facebook page. There is a live stream that will be available to watch again as soon as this ends here on Zoom. You'll be able to watch it from the beginning if you did miss any of it. In a few days, it will also be on the Multiple Sclerosis Foundation's YouTube channel. And please follow us on Facebook, Twitter, and Instagram for times and access information. Our next conference will be on Thursday, June 15th at 3 p.m. Eastern Time with Sherry Benz. And she'll be talking about what's new in MS from the Consortium of Multiple Sclerosis Centers. We always want to just say thank you to Dr. Thrower for taking all of these questions. It's a lot coming at you at once, and it's a lot to get through in an hour, but you do it excellently.
Well, thank you.
No problem. And we thank all of you guys for attending. We'll see you next time.
Take care, everybody.